RQ is a 68-year-old African-American female who presents to her family medicine physician for evaluation of her shortness of breath and increased swelling in her lower extremities. She reports that her shortness of breath has been gradually increasing over the past 4 days. She has noticed that her shortness of breath is particularly worse when she is lying in bed at night, and she has to prop her head up with 3 pillows in order to sleep. She also reports exertional dyspnea that is usual for her, but is especially worse over the past couple of days. She has a past medical history of hypertension for 20 years, CHD with a history of an MI in 2005, heart failure, type 2 diabetes for 25 years, atrial fibrillation, COPD Gold 3, Group D, and CKD Stage 4. She was a former smoker and had smoked 35 packs a year history, but quit approximately 10 years ago, and she is positive for alcohol use. Her medications include valsartan 160 mg PO BID, furosemide 40 mg PO BID, warfarin 2.5 mg PO once daily, carvedilol 3.125 mg PO BID, pioglitazone 30 mg PO once daily, glimepiride 2 mg PO once daily, potassium chloride 20 milliequivalents PO once daily, atorvastatin 40 mg PO once daily, aspirin 81 mg PO once daily, albuterol MDI 2 inhalations by mouth every 4 to 6 hours PRN for shortness of breath, tiotropium DPI 18 micrograms 1 inhalation by mouth daily, and fluticasone salmeterol DPI 250 micrograms 50 micrograms once inhalation by mouth BID. The patient is experiencing acute decompensated heart failure based on evidence of peripheral edema, which includes +3 pitting, lower extremity swelling JVD, HJR, and a S3 gallop, and pulmonary edema, which shows through crackles, pleural effusion, and dyspnea. She also is experiencing orthopnea, weight gain, and worsening dyspnea on exertion. Patient also has mild cyanosis of the lips and is pale. Based on evidence of volume overload and low cardiac output, patient is in hemodynamic subset IV, cold, and wet. ABG may be necessary to determine perfusion status. Exacerbation may have occurred due to COPD exacerbation or due to pioglitazone causing sodium and water restriction. Goals of therapy include decreasing mortality and morbidity and increasing quality of life. An IV diuretic may be recommended to reduce preload. A vasodilator may be beneficial in increasing cardiac output. Nitroprusside is a mixed vasodilator which would benefit cardiac output and volume, but it may cause cyanide toxicity due to patient's CKD. Nitroglycerin may be the better option. Patient may need to be admitted to ICU for monitoring while on nitroglycerin. Our plan is to recommend switching furosemide 40 mg by mouth BID to furosemide IV 80 mg to manage fluid overload. Recommend IV nitroglycerin 10 micrograms a minute and titrate 10 micrograms a minute for 10 minutes and a max of 200 micrograms per kilogram per minute. Recommend admitting patient to ICU for continuous monitoring, monitor vital signs, electrolytes, serum creatinine, and INR, and monitor hepatic function with ALK, FOS, and GGT for fluid status, and AST and ALT for perfusion status, and return to clinic in 7 days.